I'm going to talk about how we really need to change our approach to lipid-lowering therapy, particularly for those at highest risk, such as those with established cardiovascular disease, diabetes with microvascular disease, or familial hypercholesterolemia, and why we are missing an opportunity. So we need to move away from just thinking about high-intensity statins to now thinking about high-intensity lipid-lowering regimens and why combination therapy is the way forward. These are a list of my disclosures. I'm going to start with this, and this is one of the most important slides from the cholesterol treatment trialist collaboration. We know that cholesterol lowering by any means, it's been proven with both statins, with ezetimibe, with PCSK9 directed therapies, and also with CETP inhibitors. We know that the benefit in relative terms, the percentage relative risk reduction, basically follows two principles. One, what is the absolute lowering of LDL, and also how long that treatment is maintained. So that is relative risk reduction. But when you look at absolute benefits, you have to think about the risk in the patient population. And so we know that in clinical guidelines all around the world, there are 4 groups of patients that we believe are at high risk of cardiovascular disease. There are those people who've already got established disease, so they're at high risk of recurrent events. There are people with high risk conditions like diabetes. Now, none of these people have high levels of LDL cholesterol necessarily, but they have high risk. And then you have some people where they have one extreme risk factor, a lipid abnormality, like an elevated LDL above 190 milligrams per deciliter, for example, like familial hypercholesterolemia. And if you don't fall into these 3 major groups, then you need combinations of different risk factors, and you need some form of risk calculator to estimate 10-year risk of cardiovascular disease. So we use global risk. So if you now plot the benefits of lipid-lowering therapy in terms of now how many events you prevent over 5 years per 1,000, what you can see is the benefit relates to the absolute lowering of LDL. So the more you lower LDL, the greater the benefit. It's always there. There's no such thing as a normal LDL. Lower is always going to be better. But if you like, the number of events you're going to prevent depends upon what the risk is in the population. So if you have an annual risk of less than 1%, so 5-year risk below 5%, that's very different to the number of events you're going to prevent if the annual risk is 6% a year or a 5-year risk of more than 30%. So now in those people, even a small amount of lowering of LDL, of 38 mg per deciliter, gives you a much bigger benefit in that population because there is simply more risk. But if you don't actually get much more aggressive cholesterol lowering, you're going to have a lot of residual risk that you're going to miss. And so this really underpins our basic principles in guidelines. So now if you look at the European Society of Cardiology, ESC, EAS, lipid lowering guidelines, you'll see that very high risk categories include ASCVD, but also includes other patients, high-risk primary prevention, FH with additional risk factors, diabetes with microvascular disease. And the target for each of these is the same. It's below 55 milligrams per deciliter. So we want a 50% lowering from the starting level, and that's just an attempt to get us to try and use proper dose of statin. So not homeopathic doses like 5 or 10 milligrams of a statin, but use the more potent 20, 40 milligram regimens of the newer first generation or the third generation statins. But what you can see is that if my LDL starts at above 110, if I get a 50% lowering, I'm going to avoid getting patients to goal, because if I start, let's say, at 170 and I get a 50% lowering, I'm going to end up at 85. So anybody with a starting level of LDL untreated of above 110, if they're a very high risk patient and my goal is 55, it's going to be impossible to get them to goal with statin-based monotherapy. So we have to start that thinking. Above 110, start thinking combination therapy straight away. And you've got tables like this where you can see that once you've assessed the level of risk and you've got an idea of your targets, look at the baseline LDL and you can look at combinations of moderate intensity statins with ezetimibe, high intensity statins with ezetimibe, and you can see what you might achieve and where PCSK9 inhibitors, for example, can come in. So you can see, for example, that for a patient with a starting LDL of 155, if I use a moderate intensity statin and ezetimibe, I'm only going to get to 85. But if I use ezetimibe with a high intensity statin, I'm going to get to 54. So this is really just maths, and these tools can be really useful to guide us in terms of how we choose to use combination therapies, particularly early. Now, let's take another bit of data. This is sweetheart data. So this is an unselected population, everybody in the country coming in with an MI. And what you can see is the distribution of LDL cholesterol. So the middle is about 130. The median LDL, the peak, if you like, is 130 milligrams per deciliter. But there's a wide distribution in LDL. So some people are getting myocardial infarctions with, LDLs of 80, for example, milligrams per deciliter. Now, when they come in, they're all given cholesterol-lowering therapy in the form of statin. So 6 to 10 weeks later, we move that whole population distribution to the left. Now, 55 is my goal. And you can see that compared to at the time of hospital admission, after discharge, 6 to 10 weeks later, there are many more people to the left of the line. But because it's so hard to get to 55 with monotherapy, look at how many people are left. Now, if I maximize high-intensity statins in everybody, I'm actually not changing things very much, because when I go from 20 to 40 of atorvastatin, or 40 to 80 of atorvastatin, I'm only getting another 6% lowering. So what I probably have to do now is use combination therapy. So if you look at all of these outliers here, and I gave everybody ezetimibe, you can see I have now many more patients to the left of the line, but there may be some people still left over where I have to use more powerful agents, maybe such as a MAP. Now, we've got similar data in Da Vinci. Da Vinci was a registry that I led in Europe, nearly 6,000 patients, primary and secondary prevention. And we asked the question, when you try to manage those different categories of risk, what's your approach? And the answer is 84% of prescribing, sadly, is still statin-based monotherapy. So this basically means that when we moved from the old, easier to achieve guidelines in Europe in 2016 to 2019, we're only going to be successful with monotherapy in basically 1 in 3 patients. We're not using enough combination therapy, whether that's with ezetimibe or whether that's with a PCSK9 inhibitor. And there are cost implications as well of some of the biologics. Now, we can look at that in a bit more detail. You can see that when the goal for ASCVD patients was 70, statin-based monotherapy would get, when you maximize the statin, about 45% of people to goal. That got better with the use of ezetimibe. That got better when you added in MABs. But as soon as you basically rely on statin-based monotherapy and the goal moves to 55, only 1 in 5 is going to get to goal. So of the 4 out of 5 that is left, another 1 in 5 will get to goal with combination therapies. So we can get about 50% or so of our patients to goal with the use of 2-drug oral combination therapies. And we know that it may not be possible to get everybody to goal because there are some limitations based on availability and cost of newer treatments. But we should be using combination therapy at the outset for these patients. Now, when you look at primary prevention, the same thing is true. The low-risk patient, the goals didn't change. It's 130. So if you optimize the statins, you're probably going to get there in most of your patients. Moderate risk patients, the goal changed to less than 100. And again, if you optimize the statins, it's probably going to work. But as soon as the goal now changes to 70 or to 55, you basically are going to struggle to get patients to goal with statin-based monotherapy unless you start to use combinations, because it's just mathematically impossible to get down to below 55 simply with a drug on its own. So you've got to think about that. And this is very different to the hypertension world, where people use multi-drug combinations, often at the outset. You might say, why don't I just optimize the dose of the statin? Well, These are the average LDLs in the primary prevention and the ASCVD patient population. Primary prevention population also includes FH, so this number is a little bit higher. We know there is less use of higher intensity regimens there. But if we look on the right-hand side at optimal doses of statins, moderate and high intensity, this difference in LDL going from moderate to high intensity is only about 6%, 6 to 8%. And that tells you that in the real world, even when we get everybody onto a high intensity statins, we are still going to be just above 100. So you can't get to 55 on average in your population without combination therapy. Simple message. And the impact of this is quite large, particularly in patients with established cardiovascular disease. So this is the Da Vinci data, and this is the distribution of risk, estimated risk in our patient population. So even with statins in the background, in virtually all of these patients, 82% of patients have a 10-year residual risk of 20%. 1/3 of patients have a residual 10-year risk of 40%. So imagine that if we now bring their LDL down by another 38 milligrams per deciliter, we could reduce this risk, residual risk, by about 1/5, because the curve would move over to the left-hand side. And you've got similar data for primary prevention. So we think about risk, not just the numbers. There's additional data as well from Sweetheart that we can rely upon. So this was basically a very nice analysis where they looked at the patterns of prescribing and the implication in a post-MI patient population. And what's interesting is that most MI patients that come in are statin naive. That means primary prevention has failed. They're not being identified in the week, the day, the month, or the year before. 11% of patients get their intensity of statins increase from medium to high intensity during cardiac rehabilitation in the 3 months of follow-up. If you look at the use of ezetimibe, it goes up from about 1% to 7%, but why not 100% in this patient population? And PCSK9 inhibitors are really not used. I want to show you a couple of things. So this is the percentage reduction in LDL between baseline and during cardiac rehabilitation, which is 6 to 10 weeks afterwards. There are some people where cholesterol levels don't change and in fact go up. So these are probably patients who are either we're not adding in treatments or the patients are not very adherent. And if you look at major cardiovascular events, all-cause mortality, or any major vascular event, they have the highest risk. Most of the other patients get a statin for the first time. Now, the average reduction for most of these people is under 50%. Only a small group will get more than 50% lowering. So when you look at the percentage reduction in LDL, what you're really looking at are the people that basically get a single cholesterol lowering drug, because you'll see there's a big difference between these two groups and that one, but these two are fairly similar. And that's telling you that actually with statins alone, I'm not going to be able to squeeze out much more than 50%. It's harder for me to get to 70, 80%. This number says more than 50, but the average here is probably going to be about 55, 60, and that includes everybody above 50. So we've got to be a little bit careful, but I've told you that benefit depends upon absolute change. So instead of looking at percentage reduction, let's look at these patients again, but by absolute change. And if we break these data down by quartiles of LDL, what you will see is the group where the cholesterol levels don't change. Look what they came in with. Their LDL was already 100. And at cardiac rehabilitation, it was still 100. If anything, it was a little bit higher. It's more like 215. So why is that? Well, they had cardiovascular risk factors. They had a prior history of MI. So they were more likely to be on some form of cholesterol lowering treatment at admission. But the treatment was not intensified. They basically had no change. They came in on a statin, they went out on a statin, nobody did anything. What happens to risk? You're in the highest risk group. All of the other groups, essentially, the groups that get a small amount of change, that's 25% of the population, the groups that get a bit more change, another 25% of the population. This is the starting LDL on average, 2.8, 3.4, and they came down to 1.9, all of those patients. So basically, these are people that now we're changing their course. They get a cholesterol lowering treatment for the very first time. So unsurprisingly, they do better than this group. But what you'll see is that when you try to squeeze out bigger reductions, you'll see that the LDL that you achieve on average is very similar to these two groups. And this last curve is not that different from that red line. And that is telling you the limits of what is achievable with statin-based monotherapy. So how might we do this in practice? Well, you have in Europe the SMART risk score that the European Society of Cardiology Prevention guidelines recommended. And in secondary prevention, much like primary prevention, it's a risk calculator to estimate 10-year risk. And I want to draw your attention to this. In the UK, we validated this, and what we're able to show that the residual risk, even with statins, with an LDL of about 2.6, which is about 100 or so milligrams per deciliter, what you find basically in that patient group is that there is still a high residual risk of about 30%, 10 years. And you can think about how we should be optimizing that, and that is with combination treatments to try and bring that down much, much earlier. Behavior and physician knowledge and our care pathways need to change. This is a really interesting study. This is the ACS care pathway in Europe. This basically studied 555 physicians, almost 3,000 patients. And what it basically showed is that for ACS patients, heart attack patients, cholesterol measurements are usually done in hospital. 91 to 86% of patients had a cholesterol measurement check. This occurs within 2 days of hospital admissions. So that's good. We have cholesterol measurements, but we don't seem to be acting on it because I showed you that algorithm at the start. We're not anticipating the use of combination treatments. What happens after that is that in lipid lowering treatment is started in hospital. The average is 2.3 days. But then look at what is started. Combination therapy with high intensity with ezetimibe, only 11%. Moderate intensity or low intensity with ezetimibe, only 1%. Why is that? Because we want to just wait and watch and see what happens. But you know what's going to happen. You can calculate it. It's just maths. And let's look at behaviors. So there is something about physician bias. When you look at these patients again, if somebody comes in not on lipid lowering therapy, you basically wait and watch. You use a high intensity statin, only 1% of patients really get a very small amount of patients get combination treatment with ezetimibe or a PCSK9 monotherapy is low here, as you can see. But what you can see here is that if somebody has recurrent events or they're on a statin and they have an ACS, the doctors are already thinking, maybe I should add in ezetimibe, but why only 2%? Why not everybody? Because everybody's had a heart attack. They were taking a statin, and that basically means their LDL was too high for them. Their cholesterol levels weren't enough. And if you come in with a moderate intensity statin, look, the use of ezetimibe is higher. So now that is probably telling you something about the doctor's psychology. But I would put it to you, is this really enough, given what I've already shown you? Now, if you look at care pathways, the best way of trying to get people onto combination treatments is probably through cardiac rehabilitation. Nurses follow patterns, they recognize algorithms, and they should be doing this much better than we do sometimes. And what you can see is that even though we give clear advice to GPs, they often will not change medications because they rely on the doctors in hospital to do this. So if we as physicians in hospitals don't give clear targets like LDL recommendations, the timing of tests, but also what to do with those tests and how to interpret that, it will not happen. So you've got to give clear instructions, or you basically have nurses or other people reviewing those data and making those changes. And you can see that basically over the course of time, the longer we leave things, basically during our follow-up period, if we leave things and we don't make changes early, changes won't happen because our patients are asymptomatic. They have some improvement in their LDL. And what you're saying is, let's just wait and see what happens. Well, some of these patients will have cardiovascular events, recurrent events. So 2/3 of patients, we're getting repeat lipid measurements. Now, if they're not at goal, what we find is that many of these patients are not getting further up titration of medication. So you can see that during follow-up, 78% of people were not at goal. 59% of people were not at goal in this first follow-up, 39% not at goal, 33% not at goal. But the number of people being followed up later and later is less and less. So one of the issues that we have is that if you don't make these changes and make these changes early, you've got a real problem. So we have to remember early change is essential. And if you look at the goals of many of our patients have, even post the second update, the recent update that I showed you in 2019 and the prevention guidelines in 2021, many patients are still, the doctors are still advocating LDLs of between 70 to 99 milligrams per deciliter. So a simple pragmatic approach that we've come up with, take the thinking out. There is no cost issue for very high risk patients and extremely high risk patients. Start with statins and ezetimibe, at least of a moderate to high intensity, preferably high intensity statins with ezetimibe. If you've got extreme risk, so recurrent events in a short period of time, you should be adding in a PCSK9 inhibitor to those people in addition to statins and ezetimibe. And this makes life much easier because if you start with that combination therapy, many more of our patients will get to goal. So no further thinking or action is needed. But for those not at goal, look at adherence. Then you might look at a third drug, whether that's bempedoic acid, a PCSK9 directed therapy, maybe even inclisiran in those patients. And here we've got a table that we've created in that same manuscript where you can look at the percentage reduction in LDL that is achievable in statin tolerant and statin intolerant patients with different combinations of different agents. This is really important. We've got to start looking at the maths if we're going to change policy. So simple rule, high risk or very high risk, lower LDL goal. Monotherapy is not going to work getting people to below 70 and certainly not below 55. Real world data suggests that we've got very poor goal attainment and we're not thinking about using combination therapy early enough. So the time is now and it's time to act. So thank you for listening.